Hello, this is Allison Marcinkowski, and this presentation is on my case study on an Ebola outbreak in the Democratic Republic of Congo in 2018. Ebola virus is a deadly zoonotic disease that was first discovered in the Democratic Republic of Congo in 1976. Since then, it has mostly occurred only on the African continent. It is believed to be initially spread to humans upon contact with the bodily fluids or tissue of infected animals, such as a primate or bat. It is then transmitted human to human through direct contact with bodily fluids, whether that direct contact is with a sick person or through contact with a contaminated object. In May of 2018, the DRC declared its 9th Ebola outbreak since 1976 after 2 cases were confirmed in the Bikoro region. The Ministry of Health, along with international partners, quickly established an outbreak response that included the deployment of supplies, laboratory materials, transportation, and operational support. Between May and July of 2018, this outbreak resulted in 54 cases and 33 deaths. On May 3, 2018, the Equator Province Health Division had notified the DRC's Ministry of Health of 21 cases of hemorrhagic fever and 17 community deaths. Upon evaluating the situation, the investigation team, consisting of the Ministry of Health, Doctors Without Borders, and the World Health Organization, it was found that there were 2 patients who tested positive for Zaire Ebola virus, which is the deadliest strain of Ebola. 5 days later, on May 8th, this was officially declared an outbreak. Further investigation found additional cases in the neighboring health zones of Wangata and Eboko. By May 30th, a total of 50 cases were reported in the DRC, 21 in Bikoro, 25 in Eboko, and 4 in Wangata. 25 deaths were also reported during this time. The last case was reported on July 3rd, which brought the total to 54 cases and 33 deaths. This outbreak was declared over on July 24th, following a 21-day period of no new cases. The DRC's Ministry of Health gathered data on cases and deaths in the 3 health zones from the Equator Province Health Division, Bikoro, Wangata, and Eboko. Data from the field was collected using a standardized case investigation form, which was then entered into an electronic database. For outbreak investigations, data was primarily collected retrospectively through medical records. Current Ebola cases were classified as suspected, probable, and confirmed. Confirmation required the detection of the Ebola virus by a PCR test. Contacts were then identified and contact tracing efforts began. Through these efforts, it was found that most of the confirmed cases were exposed through direct contact with sick people prior to illness. The second most common exposure was through funeral participants. There was a rapid and well-resourced response during this outbreak since the first Ebola case was diagnosed. The DRC's Ministry of Health responded quickly upon notification from the Equator Province Health Division. The Ministry of Health deployed rapid response teams to investigate the cases and deaths that were reported in the Bikoro region. Samples taken from PCR tests were sent to a lab in Kinshasa for confirmation. After confirming positive Ebola cases, the World Health Organization was immediately notified. The WHO set up its incident management system to fully dedicate its resources to the response efforts. They provided essential technical and operational support to the Ministry of Health by activating a multi-agency emergency operations center to coordinate the response on all levels. This multi-agency response included early identification, isolation of cases, contact tracing, safe burial practices, and community mobilization. In addition, Doctors Without Borders created an Ebola treatment center in the Bikoro region. Lastly, to supplement these efforts, A new Ebola vaccine was also distributed for the first time under emergency use. Implementation of this vaccine was a key factor in the overall strategy to control the outbreak. This response was managed very well as it was able to be contained and eliminated after only 54 cases. As a comparison, previous Ebola outbreaks in the DRC have resulted in hundreds and even thousands of more cases that were able to spread more quickly across regions. The 2014 West Africa Ebola outbreak is what highlighted the need for a more rapid and coordinated response such as this one. Many authorities and the public are familiar with Ebola because of these previous outbreaks. Global health partners have also increased their monitoring, stockpiled vaccines and medicines, and have response teams on call. However, there are several gaps in outbreak management that can be addressed to better prepare for the next Ebola outbreak. The first is the leadership, which can be challenging in this country. They have a weak healthcare system, largely due to its history of conflict and political challenges. There is also a lot of distrust of the government because of corruption, as well as towards the United Nations. Efforts should be made to strengthen their leadership to ensure a timely response to future outbreaks. Also, the DRC relies heavily on international aid, which leads to logistical challenges that can prevent timely response efforts. In addition to those logistical challenges, Kinshasa is the nearest laboratory to these 3 health districts, as well as the closest airport. Bikoro is a couple of 100 miles up the river from the city, and getting there by road can take 2 days and 4 ferries. Its airstrip is also overgrown, making it impossible to reach by airplane. This makes it difficult to send supplies and personnel in a timely manner, as well as getting samples to the laboratory. Due to the frequent number of outbreaks the DRC has been known to have, it would be a good investment to establish laboratories throughout the region, especially in remote areas. According to UNICEF and its partners, over 300,000 people were reached with their awareness-raising campaign within the first month. This campaign consisted of activities led by community workers who made home visits, reached out to particularly vulnerable groups of people, and mobilized community leaders, churches, and mass media. This active community involvement was essential in containing the spread of Ebola. The communication strategy for the vaccination campaign was to provide vaccine education to healthcare workers and their contacts and spread information on the Ebola vaccine. The WHO also coordinated communication with the neighboring countries to prepare them if the situation were to change. Between May 8th and July 24th, 2018, the Democratic Republic of Congo experienced its 9th Ebola outbreak with a total of 54 cases and 33 deaths. The Ministry of Health responded quickly by notifying appropriate international partners to establish a coordinated outbreak response. They investigated all cases and contacts throughout the Bikoro, Wangata, and Eboko health zones. The main takeaway from this outbreak is that early detection, contact tracing, safer burial practices, and community engagement are key in controlling Ebola outbreaks. In addition, this is the first outbreak in which the new Ebola vaccine was used since it was found to be 100% effective in the previous testing, which was also a key factor. Going forward, the rollout of this vaccine can be proven to be essential in controlling the spread of Ebola.